Everyone, it's Hunter Hicks. Today we're going to look at some disorders of the GI tract in adults. So first, let's look at peptic ulcer disease, which we know encompasses both gastric and duodenal ulcers. So when we look at the difference, duodenal ulcers can be more likely to be caused by H. pylori and also NSAIDs. And the big difference on the presenting symptoms is we're usually going to see this more on empty stomachs. So food actually makes them feel better, whereas being on an empty stomach actually makes them feel worse. Whereas gastric ulcers, more commonly in our elderly patients, H. pylori again can cause both, but NSAIDs, chronic high-dose NSAIDs, more likely to cause our gastric ulcer. Now, food usually makes these ulcers worse, as in when they eat right after, they get that pain. Some of the protective factors in the GI system that we possibly shut down that make ulcers happen are things like mucus, bicarbonate, blood flow, and then we know prostaglandin, which is why when we have COX-1, COX-2 inhibitors, like NSAIDs, we know we block prostaglandin. There's COX-1 inhibitors in the belly, therefore we put these patients at risk for ulcers. Now, some aggressive factors that we can see is H. pylori, is a gram-negative bacteria. Now, 50%, up to 50% of people have H. pylori, but they really don't have these signs and symptoms that create ulcers. Only a certain number of people that do. Now, in general, we know that other things like gastric acid can cause ulcers, even though it's not really the amount of gastric acid, because we know a lot of patients that have ulcers don't have an excessive amount of gastric acid like they do with Zollinger-Ellison syndrome. But we know the gastric acid, if it's able to get into the mucosa, break down those things, can cause ulcers. And obviously also pepsin and smoking. Now, when we look at the treatment, some non-drug things we can do and non-pharmacological things we can do is like stop smoking and drinking, and then eating smaller meals and more meals throughout the day. Those are kind of your basic GERD things as well, but it will help here. We can give antibiotics if we suspect that H. pylori is the cause, which a lot of times it is. Usually we're giving 2 to 3 antibiotics with the PPI and an H2RA, therefore to lower the chances of resistance forming and be able to eradicate that pathogen completely. So things like lithium-iocin, amoxicillin, bismuth, and tetracycline. Now, we have H2RAs and our PPIs, very common to be seen prescribed to patients. H2RAs like famotidine, ranitidine, they block the H2 receptors or histamine 2 receptors in the belly, therefore they get less release of gastric acid. Remember when we talked about histamine in my lecture, we talked about histamine receptors both in the periphery and then also in the belly. Histamine 1 receptors are first gen, second gen, like things like promethazine and Benadryl, and then second gen is going to be more of our Claritin and stuff like that don't have the sedating effects. Histamine 2 receptors are only found in the belly, so when we block those, we get less release of gastric acid. Some of the ADR can cause some CNS effects in older patients. Both PPIs and H2Rs can increase risk for pneumonia as they raise the pH level in the belly, making it easier for secondary infections both in the stomach and in the lungs to come about. And yeah, proton pump inhibitors, omeprazole, they block the the hydrogen potassium pump, or what we call the proton pump, which is going to pump out hydrogen into that stomach. So irreversible side effects from it. So when it binds to the hydrogen potassium pump, it's irreversible. So the effects of PPIs should last for about 3 days. Now, PPIs in general are going to work faster, and they decrease the percentage of acid in the belly a lot better than your H2RAs. Now, as far as adverse reactions, obviously ammonia, again, from raising the pH, fractures from just decreased calcium absorption, rebound acid secretion. That's why we don't tend to use these things long term. H2RAs maybe are a better option for that, but we don't want our patient taking one of these every single day for the rest of their life, because once they stop taking it, they're going to get this rebound hypersecretion, which is going to be very uncomfortable. So in general, we use the lowest dose and for the lowest amount of time. Outside of that, low magnesium and diarrhea. Other kind of treatments, sucralfate is going to create this kind of protective barrier, this like jelly barrier around the ulcer, so that can be helpful. Misoprostol or Cytotec, he literally just gives us more prostaglandin. We know prostaglandin can be nice and protective in the belly, increases bicarb, decreases gastric acid release, increases submucosal flow. All those good things prostaglandin do. So when we block it, it can be bad. So we give misoprostol. We see misoprostol a lot with NSAID-induced gastric ulcers in our older individuals. Now, it can be used off-label side effect for decreasing bleeding in the postpartum hemorrhage patient. That's because it blocks prostaglandin, which we know prostaglandin induces contractions, which is why you do not want to give cytotec to a pregnant lady. Make sure they're not pregnant, because if it induces contractions, the prostaglandin aspect of it, then they'll have preterm labor. Antacids are great. They neutralize the stomach acid. So what they do is they kind of react with the stomach acid and try and create a more neutral environment. Depending on the one you're giving, there's different side effects. We have like aluminum hydroxide, which can make them constipated. We have magnesium hydroxide, which can give them diarrhea. We have a lot of sodium if we're given sodium antacids. As far as interactions, is by messing up with the pH, it can antacids can mess with the absorption of drugs, especially our H2RA. So in general, we want to give these medications 1 hour in between taking our H2RA and our antacid. So next we're going to look at some inflammatory bowel diseases, which really we refer to as ulcerative colitis and Crohn's. Though they look alike, they are a little different. Now, ulcerative colitis is going to be chronic inflammation, obviously, of the mucosa of the colon and rectum. And these lesions are more limited to the mucosa, not transmural, like Crohn's disease is that we're talking about, and they don't have skip lesions, meaning there's areas of good colon and then areas of bad colon. Those skip lesions and this transmural effect is what we're going to see more in our Crohn's disease. So signs and symptoms will have remission and exacerbations, and really what we tend to see with these patients is these frequent bloody diarrhea with purulent mucus is common. So they usually have this watery diarrhea, usually bleeding, and obviously they can have cramping and urge to defecate, stuff like that. A little bit different with Crohn's. Crohn's can cause diarrhea, but it's less likely to see bleeding with Crohn's, more likely to see that with UC. Now, diagnosis and treatment, obviously just based off the HPI, they give us imaging, cultures of stool. We want to rule out any type of infection that might be causing this. We'll get into this, but treatments, steroids, immunomodulators, which are going to have immunosuppression, sometimes possible surgery and stuff like that. Crohn's disease is a little bit different. Crohn's disease is kind of be the same thing where you have chronic inflammation, but it's from the mouth all the way down to the anus. The lesions here are a little bit different. So we have skip lesions, meaning we have good colon and bad colon, and then we have deeper penetrating ulcers, so they can get more of that transmural effect. Now, signs, symptoms, diarrhea, we can have bleeding, but it's less common to see with Crohn's. Again, treatment and diagnosis, really the same here with UC than it is with Crohn's. For IBD treatment, we can give our 5 aminosalicylates, which are good for mild to moderate IBD, glucocorticoids, which we're really using for remission. We have some of our immunosuppressants. We can give immunomodulators like all of our MABs that block TNF, which is huge for Crohn's. We kind of start with our immunosuppressants, and then we'll go into these immunomodulators, and then we'll go into our cyclosporin and methotrexate. Irritable bowel syndrome, or IBS, there's a ton of patho here, guys, tons and tons. But in general, some of the things we think cause IBS is things like visceral hypersensitivity, abnormal GI permeability, mobility, secretion, and sensitivity, alteration in our gut bacteria, some allergies to food, and then even psychosocial factors like early life trauma can increase the risk for IBS. Now, in general with IBS, we have this recurrent abdominal pain, one day per week, and usually up to about 3 months. Now, they can have totally just random changes in their bowel. It's not very specific. They can have defecation issues, like they can have increased frequency like diarrhea, they can have constipation, they can have mixed constipation, diarrhea. It just depends. When we look at treatment and diagnosis, we always want to make sure this isn't anything else. Celiac disease, lactose intolerant, IBD, which we just covered, all those sound a lot like IBS. Once we know it's not any of those things, we assume we might be dealing with an irritable bowel syndrome. So it depends on what the symptom is that's what we're treating. So maybe fiber, laxatives, anti-diarrheal, it is all depending on what they present with irritable bowel syndrome. As we know, irritable bowel syndrome can have constipation or diarrhea or a mix. So it just depends what the major complaint is, and then we treat that. Diverticular disease of the colon. So we have diverticula, which are going to be these sac-like outpoachings. When they have diverticula, which we find on any kind of imaging, then we have diverticulosis, which means they just have those outpoachings. When those get infected by whatever it might be, then we have diverticulitis, which is really where a lot of these symptoms come from. So things like diverticular disease or diverticulitis, will have lower abdominal pain and cramping, diarrhea, constipation, flatulence. As far as diagnosis, we can do a colonoscopy, we can do an ultrasound, and then treatment. So possibly there is some research out there by a more fiber diet to help than some people say not a fiber diet. So there is still more research going on with that. But in general, we give them bowel rest and analgesia for our diverticulitis patients. That's all I have. Quick, down and dirty, as always. If you have any questions, leave me a comment. Give me a like if you like the video, and I'll see you next time.